Now we are in pharmacodynamics in our pharmacology for our neetpg or next revision. So first, what the drug acts upon. The drug acts upon a target, and the target may be a receptor or enzyme, and by acting upon target, what is should it shows an effect. So drug acting on a target is nothing but known as affinity, and the target which is producing the effect, this is known as efficacy. So this is how you can understand the concept of affinity and efficacy. So once let us understand in the form of definition. So affinity is nothing but dose, that is the tendency of the drug to bind the target, that's it. Here in this you can understand. And efficacy means the maximum clinical effect which is produced, because efficacy means target which is showing finally after drug is bind what kind of effect it is showing. So efficacy mainly denotes effect and affinity mainly denotes dose. So if we combine both with together, that is dose plus effect, that is both affinity and efficacy together form the potency. We'll see potency definition later. First let us understand this by an example. For example, we have 100 beta 1 receptors and which increase the heart rate. So we know that for example we give drug A and drug B. So drug A is of 10 milligrams and even drug B of 10 milligrams. So both increase the heart rate, but drug A can increase heartbeat up to 20 beats per minute and drug B can increase 50 beats per minute. So here which drug has more affinity like drug A, because it is bound more but showing less effect, that is only producing 20 beats. But in the case of drug B, you can see it's forming 50 beats per minute, means it is having more effect, means more efficacy when compared with affinity. So like this we can compare the affinity and efficacy. So if we add them together, then we get the potency. So potency is inversely proportional to dose, means now we can say that potency is inversely proportional to affinity also, because dose denotes affinity. So potency is relative dose of a drug that is required to produce the particular effect. So I can see the terms dose and effect. So this both together is nothing but forming the potency. So relative dose of the drug that is required to produce a particular effect. For example, when the BP is low, that is by 10 we need to decrease the BP, then by hypertension mainly by two drugs A and B. So here A we are giving 10 milligrams and B we are giving 20 milligrams. So now you can say which drug is effective more, because 10 milligrams of A is only decreasing the BP, then this is more effective. So A is more effective when compared with B. So you can say that A is having more efficacy when compared with B, and B is having more affinity. That's it. And potency is inversely proportional to dose, that is here now which drug has more potency, because A means 10 milligrams dose, means less dose, means highly potent. So here A is highly potent when compared with B, because B is high, that is dose is high. We know dose is inversely proportional to potency. So if 20 milligrams the dose is high, then potency is low. So B potency is low, A potency is high. So what is a dose response curve or DRC? It is divided into two types, that is graded type and quantile type. In graded type, for example in 1% the response, it is usually in 1% and the response is graded here. But quantile type, it is taken in a population and here response may be binary like yes or no pattern. Example, you can take sedation. In a person, is there is sedation or not? Yes is sedation, if no. And pregnancy, if the person is pregnant or not, like yes pregnant or no not pregnant. Only it's like binary type, but it is graded type. So if we take a DRC curve over here, you can see we are drawing a perpendicular here 50%. This is a log dose, and here is the response curve. Response gives the percentage of the population. Example, you can take a sedation. So this gives median ED 50, which is, what is this median ED 50? It is nothing but the dose required to produce effect in 50% of the population. In the name you can understand median ED 50 means in the 50 the dose which is mainly required to produce an effect in 50% of population is median ED 50. It is a marker of mainly drug potency, that is important. So median ED 50 is a marker of drug potency. And here we are having the median TD 50, not ED, TD. TD50 is a dose required to produce a toxicity in 50% of population. So this is a toxic dose in which how much dose is required to produce toxicity, that is median TD50. Median LD50 is lethal dose, that is the dose required to kill 50% of animals. So here it is also a marker of toxicity. So both median TD50, median LD50, these are the markers of toxicity, but the median ED50 is a marker of drug potency. Next, coming to toxicity. So lethal dose divided by ED50 gives us the toxicity. Here where the ED50 tells us the potency or the dose. So here LD50 by ED50 is equal to our therapeutic index, that is the drug safety range, because here it is lethal dose and here it is the potency dose. So difference between them is nothing but the therapeutic index. So low therapeutic index means small plasma concentration, it's safe. If high therapeutic index means safe over wide plasma concentration only after the toxicity, that is in high therapeutic index. So in both this low therapeutic index and high is better because it is safer over wide plasma concentration, but only to the narrow concentration only this low therapeutic index is safe, so high is mainly safe. Next, coming to therapeutic window, it is nothing but the concentration. We can find it by concentration time curve. So this is the time, this is the plasma concentration. Here we have a MTC, that is minimum toxic concentration. This is the minimum effective concentration. So minimum effective concentration lies between this. If you draw a bioavailability of a drug, you can see it is drawn like this. So what is this minimum toxic and minimum effective concentration? Minimum effective means up to here only drug will be effective, up to here only drug will be toxic. So between these two, our aim is to form drug, aim to put the plasma concentration in between the minimum toxic concentration and minimum effective concentration. So whatever the drug we form, our aim will be to put them in the in between the minimum toxic concentration and minimum effective concentration. Now let us see the graded DRC. As we said, the DRCs are of two types, graded and quantile. Now we are discussing in detail of graded DRC. So graded DRC, if you draw a graph like this, you can check out, this is the log dose x-axis, y-axis we have response. So we need to understand here that in the graph we have points A, B, C. So among this, which have the maximum efficacy is mainly B, because whenever the graph is on higher, like it is top, then that one will have the maximum efficacy. So here B have more efficacy, next A and next C, because after B, A is somewhat higher when compared with B. So this is how we find the efficacy from the graph based on the height or slope of the DRC. And when coming to potency, how can we find out potency? If in a graph a particular one drug is towards more right side, then it is less potent. More towards left side, then highly potent. So here drug A is highly potent, next B and next C, right? So potency is like A is greater than B and C. More in the left side, then more potent. So it is mainly based on the position of the DRC on the dose axis. So that important points we need to know. So we need to understand the DRC curve. So if DRCs are parallel, they are acting on the same target. Only then we can compare the affinity. So for example, here you can see which are parallel more. Our A and B are parallel more. So we can compare the affinity for both, but not with C because it is not parallel. So like that we need to compare the affinity. So here for example, A is enalapril, B is captopril. So both are ACE inhibitors, so these both can be compared. But here C is maybe nifedipine, which is not comparable with them because we can't compare affinity for this. So this is how we find the DRC curve to find out that. Now let's see drug receptor interaction. Here we have, like for example, if we take the beta 1 receptor, which can produce 70 beats per minute, and the maximum it can produce 20 beats per minute. If we give a drug induced, it may be up to 200 beats maximum, and submaximal may be about 150 beats, and below will be 15 beats or also 40 beats. So according to that, we have given a name, like for example, the maximum drug induced effect is mainly formed by full agonist. So agonist is one which binds with the receptor and gives a maximum effect. So that is what we call as full agonist. And next, submaximal effect producing one is called as partial agonist. And the agonist, a drug which doesn't form any change, it is known as antagonist. And next, which is like giving downward effect like 50 beats per minute, then it is inverse agonist, which is giving opposite effect, and more lower one also, maybe minimum like 40 beats. So here you can see, for example, a drug A binds with beta 1 and it is a full agonist giving maximum effect, and drug B binds with beta 1 partial agonist and remains same no effect than antagonist. For example, you can take beta blockers which decrease the heart rate, so agonists can't bind. So we say that beta blocker antagonists are which don't show any effect, but beta blockers are also antagonists which show effect like decrease heart rate. So in this case, what happens is antagonist binds to the receptor, and it doesn't allow the agonist to bind there, so the agonist can't bind there and the heart rate is decreased. So like this they can act. And for example, drug D binds with the beta 1, and here the heart rate is by opposite effect, that is a inverse agonist. Next, coming to the intrinsic efficacy. So here we have plus 1, 0, minus 1. Plus 1 is maximum effect, we know it's full agonist, partial agonist in between the full agonist and antagonist. Antagonist no effect, it is the most common drug receptor interaction, remember. And in between the antagonist and below levels minus 1, we have our inverse agonist. Next, coming to the type of antagonism. So the drug which prevents the interaction of other drug is nothing but antagonism. So we have different types of antagonism, like first one is a pharmacokinetic antagonism. So here example, we can take charcoal for alcohol intoxication, and which mainly charcoal absorbs the alcohol and prevents its absorption in the GIT. And you can take example here rifampicin, which causes OCP failure, that is enzyme induction, it increases the metabolism and leads to OCP. So you know its metabolism, absorption, these are all pharmacokinetic properties, so this is known as pharmacokinetic antagonism. So the next one is the chemical antagonism. So here examples we have like protamine sulfate, which is negative and heparin is positive. So they both bind to the heparin and neutralize it as positive negative, then neutralize. So one more example is chelating agents which bind with copper and ferrum and antagonism. So here we have chemicals. So here the name is chemical antagonism. And next coming to our physiological antagonism. So here we have like they bind to the different receptors. Example histamine H1 which causes bronchoconstriction, mainly bronchoconstriction, and adrenaline beta 2 which leads to bronchodilation. Here beta 2 is used as a drug of choice for the bronchial asthma. Next, coming to the competitive type. Competitive type is divided into reversible and irreversible process. Reversible is most common. Here what happens is the DRC, you can see where the B and A, the drug B and A are binding to different sites like antagonist and agonist. So the dose response curve at the 100 milligrams looks like this. In the presence of A alone it will be like that. In the presence of B, you can see the graph height is reduced and further it is reducing. So if the dose increase, then even at B or A also increase. So right shift of the DRC is seen. Vmax is no change, efficacy no change, and potency is decrease, so that Km is increased. So how Km, Vmax are not changed, these values we will going to know by our Mitchell's-Menten equation. Later we can understand this. And next we have competitive is also known as pharmacological antagonism. So here also have irreversible type examples like organophosphates, PPI, clopidogrel, aspirin. So these are the examples of our irreversible type. Now next coming to non-competitive, like actually in competitive type what happens is both bind to the same site, so it's competing for the receptor, but in the non-competitive type they both bind at the different sites, so there is no competitive. Competitive is irreversible in DRC. So at different sites they bind. So for drug D, you can see it's binding here, it's binding here. So 30 enzymes are taken from the C. So you can see how the graph is formed. The height or the slope of the DRC is decreased in this case, and the efficacy is also decreased, Vmax is also decreased, potency no change, and Km also no change. So next let us see Mikkel's-Menten equation. For example, V is equal to Vmax into D by Km plus D. So here Vmax represents the maximum speed of the reaction, where Vmax is directly proportional to efficacy, and D is the drug concentration, Km is the Menten's constant, and V is the velocity speed of the reaction. So what is Menten's constant is nothing but the drug concentration at which the B is half of Vmax. So the drug concentration, here the dose is inversely proportional to potency, and Km is also inversely proportional to potency. So for example, if we take Km is equal to D, then V is equal to, in this formula, V max into D by, here instead of Km we put D. D into D, then 2D, D cancel, so half of V max we get. So by this equation we are forming like this equations. So Km is inversely proportional to potency and dose is inversely proportional to potency. So receptors. So according to this, here we are saying, so here we have, as we said, Km is inversely proportional to potency, right? So here we are saying potency is low. Then when potency is low, as they are inversely proportional, Km will be high. And efficacy no change, then Vmax also no change, because Vmax is directly proportional to efficacy, right? So here in this case you can see efficacy decreases, then Vmax decreases because proportional. But potency and Km max are inversely proportional. So here no change, that's it. Now let us see receptors. So we have many receptors. We need to know receptors because where the drug acts on, it mainly acts on our receptors. So we need to know the receptors. There are 4 types of receptors: ligand gated ion channel receptor, enzymatic receptors, nuclear receptors, and our main receptor is G protein coupled receptors. So ligand gated ion channel receptors, in the name you can understand their ligand is binding, and these are mainly functioning by ion channels. So here we have examples like GABA A, GABA B, GPCR, all those. And in glutamate types like NMDA, AMPA, kainate, nicotinic receptors, serotonin. And remember that ligand gated ion channel receptors are fastest acting receptors. So here the nicotinic is a muscarinic example. You have muscarinic receptor, which is a GPCR. So this nicotinic are actually the pentameric structures. 5 protein subunits are present like a flavor you can see here. Inside they have a lumen, 2 alpha subunits, 1 beta and 1 gamma or epsilon subunits are present. So the alpha subunits are constant here. They have a projections, close the lumen, interlock the lumen. So the 2 molecules of the acetylcholine bind with alpha subunit and open the lumen. So the lumen is now patent and the sodium can easily pass. Why sodium is easily passing? Because as these are ion gated channel, so every receptor is specific for one ion, and the nicotinic is mainly specific for the sodium ions. So it is acetylcholine gated sodium ion channel receptor, because acetylcholine is opening so that the sodium can enter. So you can understand here ligand gated ion channel receptors. These are fastest acting receptors, which is important. Let's coming to the enzymatic receptors. Example, we have tyrosine kinase receptor, we have endothelium growth factor receptors, HER2, insulin receptors, epithelium growth factor receptors, all those IGF, all these are examples. In this we have also what happens is first the ligand binds to an enzyme and shows an effect. So here we have JAK receptors, Janus kinase receptors for the growth hormone receptor, prolactin receptor, cytokine receptor, guanylate cyclase receptor for our AMP and BMP, and serinothreonine kinase receptor for TGFR. Next, coming to nuclear receptors. So location may be, as the name you can see, nuclear receptors is most important, and they're slow acting. So if you remember, ligand gated are fast acting and the nuclear receptors are slowest acting receptors. And remember that the location may be, as the name nuclear, they are not strictly bound to nucleus, they are also present in cytoplasm. So for example, in nucleus we have our T3 or T4 receptors, vitamin A, RX, RAR receptors, PPAR, estrogen receptor, progesterone receptor. And coming to cytoplasm, we have vitamin D receptor, androgen receptors, mineralocorticoid receptor, glucocorticoid. So all these are the cytoplasmic receptors. Next, coming to the GPCR, it's the most common target for drugs. So here we have this looks like 7 pass receptors because it passes 7 types to the membrane, cell membrane, and it has mainly inside 3 subunits, alpha, beta, gamma, and outer the ligand is binding to it. And you can see the GP protein, GDP, then phosphorylates and converts to GTP, mainly the alpha subunit, and alpha bind with the GTP and by it is converted by GTPase into GDP. So this alpha take up the phosphorate and convert into GDP. So whenever this is GDP is formed, what the alpha does now, first the alpha leaves the beta and gamma for the sake of phosphate and forms GTP. But later what happens is alpha also now lose GTP and convert into GDP. So the GDP alpha again go back to the beta and gamma and bind with them. So this process continues and this mechanism works. So this is 7 transmembrane receptor, also known as heptahelical receptor, serpentine receptor, metabotropic receptor. So among this all subunits, the important one is the alpha subunit, which is of different type like stimulatory, inhibitory, Q type, O type, etc. And it's the most important subunit. So for example, you can take stimulatory type, where what happens, alpha stimulatory gets the GTP and adenyl cyclase is activated, increase the cyclic AMP in the cell and activate the protein kinase, and this receptor is present on smooth muscle. So in the case of smooth muscle, they activate the MLCP and inhibit the MLCR, which leads to the relaxation. And even beta 2 receptor causes bronchodilation, which acts upon and causes relaxation. In case of cardiac muscle and skeletal muscle, it acts upon phosphorylate the calcium channel and opens the calcium channel, leads to contraction, and the beta 2 receptor also acts upon it and cause the palpitation of cardiac muscle, and in case of skeletal muscle they form the tremors. Next, for example, cyclic AMP is having a protein like phosphodiesterase 3 or 4, they get inhibited by theophylline like drug. So if we inhibit them, they also increase the cyclic AMP and leads to the bronchodilation. Next, coming to GQR receptor, when bound with PLC, they increase the phosphatina PIP2 and they lead to IP3 and DAG. IP3 is present in our smooth endoplasmic reticulum. They increase the calcium, and DAG activates the membrane protein kinase. And we also have GS and GQ type. For example, GS type in the smooth muscle, they lead to relaxation. GQ type in the smooth muscle, they lead to contraction. So GI decreases cyclic AMP, open the potassium channels, and GO decrease the calcium, open the potential channels. So both these are relaxing and they can also coexist with the M2 receptors. So next we have G12 or G13 type, which increase the Rho GTP. They activate the Rho kinase, which leads to smooth muscle contraction. They can be inhibited by fasudil-like drug, which leads to given in angina, cerebral vasospasm, and also in pulmonary hypertension. And we have one more drug. Actually, I don't have space here, so I turned it here, right? So it's a netarsudil, which is given for glaucoma. So this is a quick overview or a review for important next or NEET PG exam. So this is all about pharmacodynamics